Bismillahirrahmanirrahim. Dear students, today we will discuss the primary open-angle glaucoma. The learning objectives of this lecture are: we want to know about briefly clinical anatomy of structures involved in primary open-angle glaucoma, pathogenesis of primary open-angle glaucoma, and how can we diagnose and manage the primary open-angle glaucoma. Primary open-angle glaucoma is a chronic progressive optic neuropathy caused by a group of ocular conditions which lead to loss of ganglion cells and the nerve fiber layer, resulting in irreversible visual loss leading to blindness if left untreated. High intraocular pressure is the strongest known risk factor for glaucoma, but it is neither necessary nor sufficient to induce the neuropathy. So IOP depends upon three factors: rate of aqueous formation and its facility of outflow. And intraocular pressure is usually higher in the morning and low in the evening. A fluctuation of more than 5 millimeter of mercury is significant, and in initial cases of primary open-angle glaucoma, it is suspicious. Tumor formation is by the ciliary body, which consists of two parts, pars plana and pars pliccata. Total length of the ciliary body is 6 millimeter, and interior 1/3 is the pars pliccata and posterior 2/3 is the pars plana. Pars pliccata consists of 70 radially oriented ciliary processes having central vascular core covered by double-layered epithelium. Aqueous production is by three methods, mainly by the active secretion by the ciliary body, aqueous ultrafiltration, and simple diffusion. 80% is through the aqueous secretion, and the remaining 20% is by ultrafiltration and simple diffusion. Here, sodium chloride and bicarbonate is secreted by the double-layered epithelium, and bicarbonate secretion is facilitated by carbonic anhydrase, an enzyme. In this picture, you can appreciate the angle of the anterior chamber formed by the periphery of the cornea and the iris and the part of the ciliary body. Ciliary body having the vascular core covered by the double layer of epithelium, and you can also appreciate the trabecular meshwork and canal of Schlemm. This ciliary body is all around 360 around the lens, and the lens is attached with the ciliary body by the zonules, and the aqueous production is by the ciliary body into the posterior chamber. Then aqueous passes through the pupil into the anterior chamber, and then passes through the trabecular meshwork into the canal of Schlemm, and by the collector channels into the episcleral vessels and the conjunctival vessels. So trabecular outflow is pressure dependent outflow. Trabecular meshwork have three parts: uveal part, corneoscleral meshwork, and juxtacanalicular meshwork, which is close to the canaliculi. It is the juxtacanalicular meshwork which offers the highest resistance to the aqueous outflow. And in this trabecular meshwork, it is the sclerosis which causes the resistance and cause ultimately rise in the intraocular pressure. About 90% of the trabecular outflow, aqueous outflow, is through this trabecular meshwork, and 10% is through uveoscleral outflow. It is non-pressure dependent. It passes from the anterior chamber to the ciliary muscles, supraciliary and suprachoroidal spaces, and then the venous channels. Primary open-angle glaucoma can be classified into primary, secondary, and congenital glaucoma. Primary glaucoma, where no obvious cause is there. It may be further divided into open angle and narrow angle, and secondary glaucoma, where it is usually secondary to a certain disease. And congenital have two varieties: infantile first years of life, and which appear later after 2 to 3 years, that is called juvenile glaucoma. Primary open-angle glaucoma is also called chronic simple glaucoma. It is generally bilateral, though not symmetrical disease. It is characterized by raised intraocular pressure more than 21 millimeter of mercury, open angle, it means the anterior chamber angle is open, glaucomatous cupping, and visual field loss. Out of three, raised intraocular pressure, glaucomatous cupping, and visual field loss, at least two should be present to diagnose a case of glaucoma. Etiology is unknown, but genetics do play a role. Heredity is irregular penetrance. It may be due to degenerative changes in the extracellular matrix of the trabecular meshwork, leading to sclerosis and so causing the resistance to the aqueous outflow. Or it may be due to poor circulation that can produce chronic ischemia to the optic nerve head. Both raised intraocular pressure and the ischemia to the retinal nerve fiber layer or optic nerve head ultimately leads to the death of the ganglion cell and causing apoptosis of the cells, nearby cells. So pathogenesis of the primary open-angle glaucoma is increased resistance to outflow. It results into a rise in intraocular pressure, causing optic nerve damage by two methods: direct mechanical pressure and compromising the nerve head perfusion. That is called ischemic theory. So risk factors for primary open angle glaucoma: more is the age, more is the chances of having glaucoma. It is more common in blacks and in more common in females, and it runs into families, and the patients having diabetes and myopia have more chances of having primary open angle glaucoma. And the patient who have retinal diseases like retinitis pigmentosa, central retinal vein occlusion, they have more chances of having primary open angle glaucoma. And perfusion pressure, where perfusion pressure is less, particularly nocturnal drop, nocturnal hypotension, may cause more ischemia of the optic nerve head and leads to the death of the ganglion cells. Most patients are asymptomatic and unaware of any vision problem. So that's why this disease is called a silent thief of the vision. Silently, the vision is lost and patient is aware of that. So that's why this is dangerous. So whenever a patient report to you in IOPD after the age of 40, you must check his intraocular pressure and see the fundus to look any change in the optic disc. So in advanced disease, some patients may note decreased vision or a variety of visual problems, such as with night driving, fluctuating vision with reading or close work, while going from brightly lit to dim environments. What are the signs of the disease? Elevated intraocular pressure. Initially, it may be the diurnal variations. It may be more than 5 millimeter of mercury, highest and lowest pressure in any time of the day. It is suspicious. Other is the optic disc cupping and loss of retinal nerve fiber layer. Cup disc ratio is increased. cup become asymmetrical, notching may be there, neuroretinal rim is not healthy, vessels shift to the nasal side unspotted and are not equally visible on the whole of the disc. In advanced cases, they may bend at the margin of the cup, that is called Benner sign. And the visual field effects are usually in the central 30-degree. They are paracentral, nasal step, arcuate scotoma, cedal scotoma, and range scotoma. We will discuss these in later stages, one by one. In this picture, you can appreciate a normal person can see brightly in upper picture, but vision as it might be affected by glaucoma in the lower picture, the central portion is clear while the periphery is dimly illuminated. It is in case of advanced stage of the disease. This graph is showing the diurnal variation of the intraocular pressure. Intraocular pressure is usually highest from 10 a.m. to 1 p.m. So now we will discuss the three parameters by whom we diagnose the primary open-angle glaucoma, that is the intraocular pressure, defects in the optic disc, and the visual field effects. We will discuss one by one. How we measure the intraocular pressure? We can measure the intraocular pressure by Goldmann applanation tonometer, which flatten an area of cornea of 3.06 millimeter of diameter. It is very safe, easy, and accurate method. And other methods are, this is a contact method, other are non-contact tonometer as air puff, then tonopen, very small area, usually useful in corneal scar or edema. And short tonometry is an indentation method, though it is less accurate than the applanation tonometry, but it is portable. And digital pressure or digital tonometry is a crude method to judge the intraocular pressure. Here you can appreciate the slit mounted applanation tonometer. We flatten the cornea of the patient by the applanation tonometer, and when the pressure, external pressure posed by the spring of the applanation tonometer and the internal pressure in the eye is equal, then we measure the intraocular pressure. This is the end stage where two wires join one another. You can see in the picture at the central picture where we have used the fluorescein, and you can see the two semicircular touching one another. It is the end point. This is the short tonometer. We ask the patient to lie down in a supine position, put the proparacaine hydrochloride in the eye to anesthetize the cornea, then put the short tonometer plunger over the cornea. Softer the eye, more is the indentation, and then we take the reading. We measure with three different weights and then take the average of intraocular pressure. This is the air puff tonometer, a non-contact method to take the intraocular pressure. This is very good method to have screening of the patients of primary open-angle glaucoma in outdoor. This type of tonometer uses a rapid air pulse to applanate the cornea. Intraocular pressure is estimated by detecting the force of the air jet at the instance of applanation. Here you can appreciate the angle of the interior chamber. The widely open angle, that is the 45 degree according to Schaeffer grading, that is the grade 4 angle. With the help of gonioscope, if the part of the ciliary body is visible, that is the wide open angle. And grade 3 open angle is the angle which is above 20 degree but below 45 degree, usually 20 to 35 degree. In this case, the silly body is not visible by the gonioscope, and the grade 2 angle, which you can appreciate in the second picture, at the moderately narrow angle, here the silly body and sclerous spar is not visible by the gonioscope. And grade 1 angle, only it is about 10 degree, and only the Shalby's line, that is the end of the Descemet's membrane, is visible with the gonioscope. And zero angle is having the iridocorneal contact. No structure is visible, and in this case, usually acute narrow angle uh, glaucoma results. In this picture, you can appreciate the peculiar arrangement of the nerve fiber layer. They cannot approach directly to the disc, but they arches above and below the papillomacular bundle, forming arch, and the fibers respects the horizontal raphe. Upper fiber remains above and lower fibers remain below. And this peculiar arrangement results into the peculiar visual field effects when the retinal fiber layer is affected by the raised intraocular pressure or due to the ischemia. The optic nerve is composed of neuronal tissue, glial tissue, extracellular matrix, and blood vessels. Normally, 1.2 to 1.5 million axons of retinal ganglion cell are present in an optic nerve, and they are constant. And the optic disc head is about 1.5 millimeter diameter. And optic nerve and retinal fiber nerve fiber layer is supplied by the central retinal artery. The short posterior ciliary arteries supply the prelaminar and laminar region and the retrolaminar region, and also the pile vessels. This intraocular pressure gave rise, it pressurized whole of the globe. All the globe can sustain a very high intraocular pressure, but the lamina cribrosa, a sieve-like structure where the retinal nerve fiber layer passes, it cannot sustain the high intraocular pressure, so it bends down, and ultimately, due to this pressure, results into the death of the retinal nerve fiber layer. So glaucomatous optic cup is caused by two methods. There are two theories are postulated to cater for the death of the retinal nerve fiber layers. Initially, the vertical portion, upper and lower fibers are involved. By mechanical theory, it means the direct compression of the axonal fibers at lamina cribrosa. It interrupts the exoplasmic flow. It leads to death of the retinal ganglion cells. In the ischemic theory, it causes decreased optic nerve perfusion. Ultimately, the both processes lead to death of the retinal ganglion cells, leading to apoptosis of the nearby cells. What is a cup disc ratio? It is the ratio of cup to disc size. Normal size of the disc is 1.5 millimeter, and normal cup disc ratio is about 0.2 to 0.3 millimeter. Normal physiological cup is a saucer shaped where vessels passing over the cup are visible throughout. But once the degeneration of the retinal fiber layer occurs due to the high intraocular pressure, due to mechanical injury, or due to the low perfusion, ultimately the cup becomes deeper, excavated. So the retinal vessels which come from posterior central retinal artery, which comes in the center of the optic nerve. Once it divided into its branches, they are no more supported and they shift towards the nasal side and they bend around as they passes from the margin of the cup, of the glaucomatous cup. Here you can see the glaucomatous optic neuropathy. On the left hand picture, a concentric enlargement of the cup is there, and on the right hand picture you can appreciate the nasal shifting of the vessels and bending of the vessels at the margin of the optic cup, and more enlargement is in the vertical portion of the cup, and the neuroretinal rim is not healthy. In this picture you can appreciate the progression of the glaucomatous cup. The progressive optic cup is the more diagnostic than if you see the bigger cup initially. In this picture, you can appreciate in picture A the normal cup disc ratio, that is 0.2, and in B concentric enlargement and cup disc ratio is about 0.5. In the picture C, inferior expansion with retinal nerve fiber loss, and picture D, superior expansion with retinal nerve fiber loss. In picture E and F, advanced cupping with nasal displacement of vessels. And in last picture, total cupping with loss of all retinal nerve fibers. And here you can appreciate the oval gray dots, which are called laminar dots. Once the retinal nerve fiber layer is degenerated, these pores in the lamina cribrosa are visible. They are called laminar dots. The other peculiar glaucomatous visual field effects, we can judge these visual field effects by the automated visual field analyzer. We ask this investigation central 30-2. Central means central 30 degree and 2 means 2 millimeter target. And normally visual field effects are the bearing of the blind spot, then the paracentral scotomas. Once this paracentral scotomas join with the blind spot, it is called arcuate scotoma. In this picture C, you can appreciate the superior arcuate scotoma, and on this, if there is inferior arcuate, then it is called double arcuate scotoma. In the picture D, you can appreciate the nasal step, and the temporal visual field and central visual field is spare. In the picture E and F, temporal visual field and part of central visual field is paired. Ultimately, this temporal visual field is extinguished and only central visual field is left behind. And if untreated, ultimately, total blindness results. A new method of investigating the primary open-angle glaucoma is the way, with the help of optical coherence tomography, we measure the thickness of the retinal nerve fiber layer. In this picture, above pictures, you can appreciate that around the disc, the retinal nerve fiber layer thickness is shown. Red is the thickest, then orange, then gray, blue. And in below pictures, all the four quadrants are showing the deviation map. Red is the affected one, yellow the borderline, and green is the normal. The same right nerve is more involved, superior and inferior quadrant is more involved, temporal is on borderline, and nasal is healthy in the right eye. Right eye is more involved than the left. What is the normal tension glaucoma? Normal tension glaucoma is defined as glaucomatous disc and visual field changes with IOP consistently less than 21 millimeter of mercury, though the other signs are the same as primary open-angle glaucoma, having increased cup disc ratio and peculiar visual field effects. Here the cup is relatively large as compared to the visual field loss. Disc hemorrhages may be there. It is more common in females, more common in Asians, having history of cardiovascular diseases, vasospastic phenomena, migraine. So the cause may be decreased perfusion due to systemic diseases like arteriosclerosis, hypertension, diabetes, anemia, then the low perfusion due to nocturnal hypotension are the causes. In this picture, you can appreciate the splinter hemorrhage on the disc, which is a common feature in the low tension glaucoma. What is ocular hypertension? Ocular hypertension can be defined as raised intraocular pressure more than 21 millimeter of mercury, where the optic disc and visual field defects are no more there. Optic disc is normal and no visual field defects are present. So it should always be considered as glaucoma suspect, as many as it may transform into primary open-angle glaucoma in due course of time. So you have to examine the patient after equal intervals, after 6 months or a year. Now we come to the management of the glaucoma. The factors which you must consider while managing the primary open angle glaucoma are the initial intraocular pressure, extent of optic nerve damage, and compliance of the patient. The aim is to achieve the target pressure, and the target pressure is a pressure where progression of the disease is halted. No more progression is there, and you can judge the progression by the serial visual field screening or the OCT. And the 30 to 50% reduction in the intraocular pressure, initial intraocular pressure, which causes the damage, is usually sufficient to halt the progression of the disease. That is the target pressure normally. What are the different methods of treatment of primary open-angle glaucoma? Two methods, medical and surgical. The primary treatment of the primary open-angle glaucoma is the medical. If it fails, then we intervene surgically. Normally, we use beta blockers, carbonic anhydrase inhibitors, prostaglandin analogs, alpha-2 agonists. Nowadays, we use prostaglandin analogs as a first-line drug. They enhance the uveoscleral outflow. Beta blockers and carbonic anhydrase inhibitors, they reduce the aqueous humor formation. Beta blockers block the beta receptors present in the ciliary body, which are essential to form the aqueous. And carbonic anhydrase inhibit the enzyme carbonic anhydrase, which is required to form the bicarbonate, secretion of the bicarbonate, which ultimately lead to the secretion of the aqueous. And the different surgical methods are organ laser trabeculoplasty, trabeculectomy, different filtering procedures. Cyclocryotherapy and cyclolaser ablation is done where the vision loss has occurred, and we only want to control the raised intraocular pressure to make the patient comfortable. And orotomy is usually in case of narrow angle glaucoma, not in case of primary open angle glaucoma. In primary open angle glaucoma, trabeculectomy is the answer. In left hand picture, you can appreciate the organ laser trabeculoplasty. We target the trabeculum with the organ laser. It causes sclerosis of the trabeculum, causing stretching of the trabeculum, which opens the pores, so the facility of aqueous outflow is increased. This usually vanished after 5 years. On the right hand picture, you can see the trabeculectomy procedure where a new exit channel is created, half the thickness. We raise the half thickness of sclera about 4 into 4 millimeter, and underneath sclera about 2 into 2 millimeter along with trabeculum and peripheral part of the iris is excised. So a new channel is created bypassing the pupil and the trabecular meshwork, and the aqueous passes directly through this iridectomy hole and the cut over trabeculum and passes underneath the subconjunctival space directly. This was all about the primary open-angle glaucoma, my dear students. Now I am giving you an assignment which you have to complete and respond on the given WhatsApp number and email same day as soon as possible, and your attendance will be marked on the basis of your response. And the assignment is, how will you diagnose and manage a case of primary open-angle glaucoma? Thank you very much, ladies and gentlemen, and my dear students, for patient listening. Thank you.